Hello everyone, welcome to the November Mental Health Nursing Research Unit Journal Club. So just to let you know, we are recording the session, just if you want to make decisions about whether to ask questions or turn your camera off and things. Delighted to welcome Professor Ben Hannigan from Cardiff University here this month to talk about his paper, Care Coordination as Imagined, Care Coordination as Done, Findings from a Cross-National Mental Health Systems Study. So I'm going to hand over to Ben in a second, but just to say using the usual format of Ben's going to talk about the paper and some of the key findings from the paper the first 15-20 minutes, and then we should have 10-15 minutes at the end for some discussion, some questions. So I'm going to turn my camera off, and people could do the same, and then when we come back for the Q&A, we can sort of put cameras on to ask questions. So I'll hand over to you, Ben, if that's all right.
That's great. Thank you, Rob. And hello, everybody. I'm really bad at reining myself in, actually. I can talk and I can talk and I can talk. So I'm going to have to be very, very, very disciplined and try not to just talk at everybody for the next 30 minutes. So haul me up if I'm over talking, because it would be really useful to have a discussion. So what I'm going to present today, and I'm not going to use slides, I'm just going to talk to this paper. Our findings they arise from the COCAP study. So I probably need to say something about the COCAP study first of all. So COCAP, or Collaborative Care Planning Project, was a large study led by my friend and colleague Alan Simpson, who's now Professor of Mental Health Nursing at King's College London. And we investigated care planning and care coordination across England and Wales. And there were a number of elements to this. There was a comparative policy analysis across the two countries, and there's quite a story about the convergent and in some cases divergent policy context for mental health care planning and coordination across England and Wales. And then we conducted an in-depth case study, comparative case study analysis, where we generated data across 4 NHS provider trusts in England and 2 university health boards in Wales. And in between the policy analysis and the case study data generation and analysis, we also conducted a meta-narrative review, which is a certain type of literature review, which looks, if you like, for trends or patterns in the types of or the communities of literature that have accumulated in a given area over time. And once we kind of published from COCAP, and so that involved, given that the study was funded by the National Institute for Health and Care Research, Health and Care Delivery Research Programme, so our first obligation was to publish our final report. So that's on the NIHR Journals Library if anybody wants to download and read that. And we also published some more succinct derived papers. This paper, the one I'm talking about today, arose largely as a kind of if you like, an opportunity, because for a long time I've personally been really, really interested in complex systems and the journeys that people who live with mental health difficulties take through those complex systems. So the paper that's presented in this particular article I'm talking about today, if you like, arose as an additional piece of new analysis and a new paper that doesn't in any way replicate the kind of material that you'll find if you go to the COCAP NIHR journal library report. And the starting point was this: if any of us were to speak to, and I would imagine that there are lots of people on this call or maybe listening to this hereafter via the YouTube upload, if we speak to anybody who is a community mental health care coordinator, a very common refrain is, this is a lot of work administratively. There is an awful lot of paperwork, there's documentation, there are things that need to be done electronically or on paper, and that's a refrain that goes at least all the way back to the mid-2000s, when people first started investigating the care program approach, which Alan Simpson did for his PhD, for instance. So the question then seems to arise, if care coordination is such a task, if it's such an administratively burdensome task, why on earth do we do it? And the reason that we do it, I think, is because we kind of have to, and we have to because the experience of living with a long-term mental health, or indeed any or a physical health condition, is in and of itself something which creates uncertainty, and the system through which the health and social care system, through which people receive support, care, interventions, that in and of itself is also very complex. So think about the division of labour in the community mental health system. Think about the different agencies and organisations, the different teams that have to make a contribution. And because of these two reasons together, factors or features associated with the health and illness experience per se, and factors associated with the system, this creates a real imperative on what we might call, and what people like Anselm Strauss, sociologist of medical healthcare work, call trajectories, and trajectories that particularly need articulating. So the journey through a system can go off in all sorts of directions, and that needs somehow to be managed, it needs to be articulated, or in the language that we more typically use in mental health systems, it needs coordinating. And trajectories can be knocked off course because, for example, people might be admitted to hospital and there are no beds, or there's a gap in a service and there are deficiencies in the kind of people able to do the work that's needed, or indeed because people have crises, all sorts of or people can, if you like, lose touch with services. And if we then look from that kind of starting point, that premise around system complexity, which gives rise to the need for care coordination, if we look back to the, if you like, think of it as a potted history of the institutionalization or the formalization of approaches to care coordination or care planning and care coordination of mental health services. And that, of course, goes back to the time when I was working as a community mental health nurse. It takes us back to the beginning of the 1990s, the NHS-led care programme approach, the CPA, and that's quite a policy story over time. And there are some really important and interesting differences in the way in which formalised systems for the coordination of care have unfolded across England on the one hand and Wales on the other. But if any of us were to dig up the original 1990 Department of Health circular and see what that said about care coordination, we would find that a remarkably dry and a remarkably technical document. It just said that everybody who is discharged from hospital will have a care plan and they will have a care coordinator, and there will be some process for the review of people's care. You'll find nothing whatsoever in there about values or principles that might underpin the way in which that care planning and that care coordination is done. But if we kind of trace that policy analysis over time, and we kind of move from the 1990s and we move into the kind of we come to the middle of the 1990s and we look at things like building bridges, which the Department of Health published in 1995, where the CPA was described as the cornerstone of mental health care. We then get modernisation of care planning, care coordination. In England in the late 1990s, where we have words like key worker being replaced by care coordinator. And in Wales, where formal systems, if you like, of care programming arrived a bit later, we get documents published by the Welsh Office in 1996, then by the newly devolved Welsh Government in 2003. What we see, and in Wales, for people interested, we actually see care planning, care coordination being elevated, not just to the level of policy and guidance, but also in law. So in Wales, we now have something called the Mental Health Wales Measure, which is the equivalent to an Act of Parliament in Westminster. So it's a Welsh government law, which creates very, very, very clear very clear law on everybody who uses secondary mental health services needing a care plan, needing a care coordinator, and even prescribing the professional groups who can do this work. And across that kind of potted history, the other thing we see, so it changes and there's new policy and there's refocusing and there's modernisation, there's law in Wales but not in England. We also see the language underpinning care coordination and care planning becoming less technical. So it's not like the original 1990s document, but it becomes much more about care planning, care coordination being a vehicle for the provision of values-based or principles-based care. And what might those principles or values be? Well, we wouldn't be surprised to know, or to reflect on how the values or the principles that care planning and care coordination are now intended to deliver, or to be a vehicle for, are indeed the principles or the values of recovery. So the means through which recovery-focused care might be provided to and received by people using mental health services is indeed formalized processes of care planning and care coordination. And that kind of observation, that potted history, that shift from a very dry technical approach to coordinating care to care planning and care coordination being a formalized system for the provision of principles-based or values-based care, that's what kind of gave rise to this new analysis of some of the data generated in the COCAP study, in order to ask the question, to what extent is care coordination, as in the minds of policymakers, the people who are at the blunt end of care provision, to what extent is that imagined values-based activity of care planning, care coordination, reflected in the realities of what care coordinators do, or what care coordinators talk about, what they do when they talk about care coordination. So if you like, it's a kind of a study or a reanalysis of data to investigate the gap that may exist between the policy aspiration, the imagined work that care coordinators do, and the actual work as it's described by people who do the work on a day-to-day basis. So the blunt end versus the sharp end, if that makes sense. So the data set that we used in this study, so we'd already, as I mentioned before, we'd already conducted an analysis of the care coordinator, the senior manager and practitioner, the service user and the carer data across the 6 case study sites, in which we generated data in the COCAP study. So for this paper, we extracted from the much larger data set the 28 interviews that had been conducted with care coordinators across the 6 NHS case study sites, 4 in England, 2 in Wales. So there will have been nurses in that group. There will have been members of other professional groups. And we conducted a thematic analysis guided by a very clear focus on understanding, from the point of view of those who had been recruited into the study because they are indeed care coordinators, a thematic analysis focusing on an understanding of how care coordination is done in the day-to-day from those at the sharp end who are doing care coordination on a day-to-day basis. And we created 3 themes, and our 3 themes were engaging, attending and supporting recovery, connecting and mobilizing, and accommodating and adjusting. And under the engaging, attending and supporting recovery theme, we detected and brought together all the data that care coordinators had given us in all those 28 care coordinators in the interviews that we conducted with them, which pointed, if you like, to the relational work, the interpersonal relational work that care coordinators do when they coordinate care with people using secondary mental health services. So, for example, we get care coordinators saying things like, well, the person using services gets a full package of care from somebody who does what she says they're going to do. They're reliable. It gives them a sense of, their problems are being listened to. They're being supported in the community. Gives them hope that they're on the road to recovery, and things will get better. So there's a sense there, really, in which for this person, that this relational or engaging, attending and supporting recovery part of care coordination is fairly close to the vision of care coordination as it's imagined by people who are writing the policy. And care coordinators were clear that engaging and attending also meant tailoring services. It meant thinking about the individual needs that people might have. So putting the person using services at the centre. So a care coordinator, for example, told us that it's sitting down with a patient, it's their individual care and treatment, it's theirs, it's patient focused, it's tailored to them. And then what about connecting and mobilizing? Well, this is at the heart of what care coordination maybe is about. It's the articulation of trajectories It's the helping to bring the person to the system, and the system to the system to the person, and the person to the system. So, for example, a care coordinator in a data extract that we brought underneath our connecting and mobilizing theme. So, well, let's say, for instance, if a patient gets admitted to hospital, it's my role as care coordinator to ensure this is happening, that's happening, that's happening. It's not necessarily me doing it, the work that needs to be done. I could just care coordinate, for example, with the ward and say, well, can you do it, or can you book it in? Let me know. It's just ensuring things are done. So the example here is maybe somebody who is now moving from the community into hospital. There's a job to be done to make sure that things are happening, the transition takes place in the way it should. And that, if you like, is a really key part of what the care coordinator is doing. And it's also demanding work. It takes time to do this. So care coordinator says, well, what you basically do is you're the manager of provision of care for someone suffering from mental health difficulties. So it's a person who's organizing, overseeing the whole delivery of support to someone, tries to keep a track of the different services and professionals involved, while keeping the service user informed of everything that is happening. So lots and lots of really important linking work, linking one team to another, linking community to hospital, linking one professional group or service to another. And yet, under the accommodating and adjusting theme, there was lots and lots of talk, and this takes us all the way back to the early 1990s research on care planning and coordination, where the emphasis was very much on the administrative burden. So there really was a lot of adjustment and accommodating that care coordinators needed to do to reflect changes in the context or the larger framework for the work that they were doing. So a care coordinator says, well, one of the annoying things about it is how the format changes. They bring out paperwork. You get your caseload, you're told you need to get all your caseload up to date, and you need to use this paperwork, so any previous paperwork isn't acceptable anymore. Another says it becomes more a paper exercise because you have to meet the targets every month. And it's a reminder, is the care plan done? Is that done? IT systems were cumbersome. And this implementation of care coordination, the constant adjustment to processes and systems, was a deflection and a distraction, but was a significant part of the work that care coordinators described that they were doing. And how about the influence of recovery values on their work? So this was interesting, and there were different views of the extent to which care coordination might indeed be a vehicle for the provision of principles-based or values-based care. So some said, for example, that recovery actually was a premise for the discharging people. So a care coordinator said, I think, right, well, if I can't keep thinking of aims and outcomes with the people I'm working with, then they're going to say that I don't need to be under the team anymore, because I do find some long-standing patients are really clutching at straws of things. So care coordinators worried, if you like, that recovery was being usurped or being interpreted in very different ways, with a view to actually managing people away from services. So how do we kind of summarize all this? First of all, people who design, it's designing policies, designing standards, writing national guidance or law for the work that health or social care professionals do, like how to coordinate care, is not the same as actually doing that work. Professionals inevitably have to make choices. They have to do the real work at the sharp end, which means that what they end up doing often is quite difficult from what people at the blunt end imagine that they are doing. To what extent is care coordination in reality an imagined values-based work? To what extent is it being done in a way that people at the blunt end might imagine it is? Yes, absolutely. There are instances we found on our data of engaging and attending and of collaboration, but for others, care coordination was actually, or incorporation of recovery ideals, was a way of actually withdrawing specialist mental health care, particularly at a time of scarce resources. So what do we do about this? In England, of course, I'm aware that the CPA has disappeared in the context of the community mental health framework. We still have law, primary legislation in Wales. My view on this is that care coordination, for the reasons I gave at the beginning of this talk, is work that completely definitely has to be done. Systems are complex and people's journeys through those systems are complex. And it's important work to do to bring people into the system and to bring the system to people. Whether it needs to be done in the way it's currently being done is another question altogether. And whether it could be done differently or better is something I'd be very interested to hear people talk about. There we are, potted study, 2:20 on my clock. Time for questions or discussion.
Perfect timing. Thanks, Ben. That was a fantastic summary of a really interesting paper. So we've got 10 minutes left for questions. People can either put the hand up and I'll invite you to unmute, or you can put a question in the chat. I can see Karen's already put a question in the chat. I don't know if do you prefer to unmute and ask your question, Karen?
I can do, yes, I can do. Thank you. Yeah, thank you. So, hello, Ben. Lovely to see you.
Karen, lovely to see you too.
It's a treat in the day. Anyway, so the question was, I read the paper. It's really excellent paper. So thank you for presenting it. But right at the very end, in your conclusion, you talk about the fact that the care coordinator role often sits on the margins of individuals' competency.
Ah, yes.
And, you know, given that 4 years on, and we've had a pandemic in the middle of it, and CPD funding has not done any better out of the last 4 years. Are you aware of any advances in providing support or training for people doing the care coordinator role, or anything planned, or anything in an ideal world that you would love to see?
Okay, I'll have to just confess and say I don't, but that's probably because my eye's been off the ball a bit and I've not quite so actively been in this area as I was at the time which the paper was written. So it could be that this is saying a lot more about my ignorance than it is about whether or not anything actually exists. But I can say something about the competency word, though, which is where you began in your question, Karen. It's to do with the tension between, and there was a little bit in the data, one of the data extracts I just drew people's attention to. So it's the care coordinator who says, well, of course, I don't need to do everything. I don't need to be the person who provides that intervention or that type of support or that particular kind of treatment. But I am the person who needs to make sure that that work is done, possibly by somebody else, because that's meeting an identified need that we've assessed and we've written in the care plan and so on and so forth. However, elsewhere in the data, which I don't think I've actually talked so explicitly to in this short presentation, is a care coordinator, for example, who says, actually, I often end up doing things because I'm the care coordinator, the work falls to me because there might not be anybody else in that kind of small team that surrounds that person who has the time or the space or the capacity to be able to do that work. And that's where potentially the boundaries of the work that professionals do is extended. So for instance, what's the education or the training or the support that community mental health nurses might get to help with people's housing needs? And yet, if a housing need is identified and a care coordinator is the person on whom that falls, not to do the work, but they find that they can't find somebody who has got those skills, what's the likelihood that that practitioner has their work kind of stretched, the boundary is pulled, and what does that tell us about the needs for certain types of education, training, supervision, ongoing support, and so on? So it's when coordination becomes conflated with doing of the work as opposed to coordinating the work. And this kind of thing, this is not the only study where we found this kind of this kind of this we that people talk about, the other kind of research studies I've been involved in have found similar kind of things. My PhD, which completely predates this, there were clear examples of professionals doing work that was at the boundaries of what they were prepared for because there were gaps, absences of colleagues in the team, and yet there was a felt need to respond to do things to support people in the way that they needed. So that's the competency thing. But your question about what's happening now, I don't know. Other people might know, of course.
Yeah, and also since nobody else has got their hand up, I mean, we tend to use the word proficiency rather than competency in lots of
yes.
But this is nowhere to be found in the NMC standards, is it?
No.
Nowhere to be found.
No, and yet it's so important, Karen. It's so it's so important. It is really interesting, isn't it? You know, I speak to students, for example. They might say, "Oh, this is so, but I have to do all this and do that. I have to coordinate care." And I think it's not why people come in to do mental health work, particularly because they come in to do mental health work because they want to be helpful, and that's they're thinking of maybe therapeutic, interpersonal therapeutic work that they will do with people, which is really, really, really important. But this coordinating work is also really important. If it doesn't happen, then what are the potentials for people's complex journeys through a complex system?
Yeah, lovely. Thank you.
Thanks, Karen. It's a great question. Ali, you have your hand up.
Oh, hi. Yes, it was really interesting, and I have been a care coordinator quite recently, in recent years, and I found the paper really interesting. Mine's more of a comment, really, in that what you just said there about stretching the boundaries of proficiency and competencies, that is the thing that really has the biggest impact on your ability to build on those therapeutic relationships, because if you are being pulled off to do commission, I'm a CPN, like, by training, but a lot of my role was a lot of commissioning based work that just took up so much of my time that actually then when I was having to say to people, I was trying to build relationships with people, and actually such a large portion of my day was this administrative work, and it just actually had an impact on the part of your job that makes it easier.
Yeah, the administration, that theme of whatever we call it, whatever variant of CPA or post or pre-CPA, however it's kind of wherever we are in that kind of policy timeline, it is consistently described as work that is consuming. It'll take as much time as people have available to give it, and this kind of upheaval in terms of systems and processes and documentation and paperwork. I mean, there was some data I haven't particularly highlighted again in this presentation. It's in the paper though, around the care plan being used as part of kind of contracting or commissioning. So they have to be counted, because otherwise you're not going to get the kind of, I mean, this is much more familiar to people in England than in Wales, different kind of policy differences across the two countries. But, nobody would have had this in mind when care planning, care coordination was kind of thought about and initially formalized. Actually, the product of that becomes important to bring money into a community mental health team or a recovery team or something.
It's a really I think it's a useful tool for people to prove what you're doing, but actually then by using that as a tool, it then becomes the driver rather than the actual work that you're doing. So I think the word useful there, I shouldn't have used it in that way, but do you know what I mean? Like,
I do, yeah.
People see it as a good way to kind of, yeah.
Karina, that's Karina's just saying goodbye. Nice to see you, Karina. Yeah, no, Ali, yeah, you're right. It's good. Yeah, nice to meet somebody who's currently care coordinating rather than somebody who did it like years ago in my case.
Slightly frazzled, but okay.
Thanks, Ali.
Okay, thank you.
So we're coming up to time. I see Mick's got his hand up, so we've probably got time for one more question before.
Yeah, let's definitely. Yeah, Mick. Yeah.
Hiya, Ben.
Hiya, Mick.
I had a great paper. I enjoyed reading it when it first came out, and the other papers around that study as well. Some really good stuff. I've just been reading a book by a fella called Rich Moth, who comes from a social work background, and he did a very lengthy ethnography of community mental health teams. It covers sort of similar ground, and one of the things he gets stuck into is some theorizing around why things might be the way they are, from a sort of premise that a lot of what practitioner staff are being asked to do, particularly around things like care coordination and risk management and everything, is sort of servicing the system more than sort of necessarily servicing the patient. And he sees the system as having a sort of insatiable desire for information, data collection and monitoring, and not so much interest in the sort of relational elements of care and support that you emphasize. So I see a lot of similarities between the two. Now, Rich firmly casts that in a wider politic, if you like, and says that these sort of trends are inevitable because of the way wider society is organized. So then sort of psychiatry and the psych professions serve those sort of interests, and the dominant interest is for commodification, saleability, and within markets, sort of management of information becomes profoundly more important than the welfare of people. So I just wondered what your thoughts are on all of that.
And yet in the face of that, which I'll need to either send me an email about. I want to look at that book actually, because that does sound very interesting. Actually, I'd not come across it there till you mentioned. But in the face of that kind of the system putting all these kind of commodifying, quantifying demands on practitioners, in that kind of space, where the acting with agency professional is able to exercise their discretion and do their work beyond the kind of reach of what the kind of imperative from the system are the examples of people who are still committed to and are still, despite all the things that are happening, are still really attending to the person, are still listening, are still engaging, and are still committed to the provision of, care that is premised on the value of the interpersonal, despite the fact that the system is exerting all the forces that it does, which from your description there, I recognise that for sure. I need to go and read that though, which sounds interesting. But yeah, that kind of little wiggle room that people have.
Yeah, I think you're right. Sorry to come back at you there, Ben, but I think you're definitely right, and I think Rich and others also talk about the opportunities to work the cracks of the system where the neoliberal regime, if you like, is not always paying attention to what we're doing. And I think that's the case for the service users and patients as well. So he sees a corollary, you can't say the word, linked to this. It's a sort of trend to try and make the individual more and more responsible for what's wrong in their life, to the neglect of the big issues in society that might be troubling them. And he calls this, he's not the first one to say this, a sort of responsibilization of the individual. And I've forgotten where I was going with this. Yes, but people themselves can resist this as well, and they do. But sometimes their resistance kicks against the sort of help and support that we're trying to provide as well. So it gets very, very complicated, I think.
It does, yeah.
We're coming up to time, guys. It's a topic that we could talk about for hours. I'm going to try and do my job as chair and keep us roughly to track. So would that be an all right point for us to finish for today? And
fine by me.
Ben, if people have questions, are you okay for them to contact
Yeah, of course.
you?
Yeah. I'm easily searchable. I'm by all means.
Fantastic. Well, thanks very much for doing that, Ben. Really appreciate it.
Enjoyed it. Lovely.
Great. Good discussion, everyone. Just to say, we've got another session of the Journal Clubs coming up next month. We have Una Foy from King's College London, who's presenting one of her papers, so that should be really good. And just a plug to say, lots of people on this call who've actually presented now at the Journal Clubs, and we have recordings of these sessions on the Mental Health Nursing Research Unit website. So there's a really nice repository of past sessions and discussions about papers that are really relevant to the practice of mental health nursing. So if you've not checked them out, I would encourage you to do so. But if we'll finish there, if that's okay with everyone. And yeah, thanks very much, and I hope to see you all again soon.